And here is etiological classification. The type 1 diabetes, type 2 diabetes, and specific type of diabetes, and fourth is diabetes of pregnancy. So type 1 diabetes, it is immune mediated beta cell destruction, usually leading to absolute immune deficiency. Type 2 diabetes, it is usually predominantly insulin resistance with relative insulin deficiency to a predominantly insulin secretory defect with insulin resistance. And there are type 3 is specific type of diabetes, we will see in the next slides. So type 1 diabetes is autoimmune diabetes, and due to some infection at young age which lead to development of autoimmunity in later ages, which leads to insulitis, which is inflammation of the insulin producing beta cells, and later there is destruction of beta cells and deficiency of insulin secretion. In type 2 diabetes, it is predominantly insulin resistance in obese patients with relative insulin deficiency. Later they will develop absolute insulin deficiency, though it is less severe than type 1 diabetes, and so they do well on oral medication to control it. After 10 to 15 years of diabetes, they will require insulin for better control. Type 3 diabetes due to a specific type of diabetes, and it may be due to genetic defects or transient neonatal diabetes. Genetic defects will be in the beta cell development or its function, leading to development of maturity onset diabetes type of young, which is termed as MODY. Type 1, type 2, type 3 and other types of MODY may be developed. Another is transient neonatal diabetes. Disease of exocrine pancreas may also lead to diabetes. This has been included in type 3 diabetes mellitus. So any disease of exocrine pancreas like pancreatitis, pancreatectomy, neoplasia, cystic fibrosis, hemochromatosis, fibrocalculus pancreatopathy, mutations carboxyl ester lipase, genetic defect in insulin action including type A insulin resistance, Leprechaunism, Robson-Mendenhall syndrome and lipodystrophy syndromes. These all can lead to, are included in type 3 diabetes mellitus. So we saw already the endocrinopathy can also lead to diabetes. So acromegaly, Cushing syndrome, glucagonoma, pheochromocytoma, hyperthyroidism, somatostatinoma and aldosteronoma. Drug induced and chemical induced. Nowadays this entity has become very common due to COVID infection, which was treated with high doses of steroids. So glucocorticoid is the main cause of drug induced diabetes, which is a good example. Another drugs are Vacor, pentamidine, nicotinic acid. Even beta blockers have been, particularly atenolol was incriminated for development of diabetes who are taking from long time atenolol. Also thiazides, they can cause diabetes mellitus. Calcineurin and mTOR inhibitors, hydantoins, alpha interferon, all these were known to cause diabetes. Infections, so congenital rubella, CMV virus or Coxsackie virus are good example which have been suspected of causing development of diabetes. Uncommon form of immune mediated diabetes like stiff person syndrome, anti-insulin receptor antibodies. So these all are included in type 3 diabetes mellitus. So endocrinopathy, as we saw already, acromegaly, Cushing syndrome, glucagonoma, hyperthyroidism, somatostatinomas, and the drug we already discussed. Infections we already told you, CMV, congenital rubella and Coxsackie virus. So many of endocrinopathy, drugs infection and immune mediated disorder can lead to development of diabetes mellitus. Many of the common genetic syndromes are now associated with development of diabetes mellitus in later life. So it is at most important to look for diabetes mellitus in such patients and counsel parents of such children about development of diabetes mellitus in these children at later age. So these are genetic syndromes which are commonly associated with diabetes. The commonest most is Down syndrome, Klinefelter syndrome, porphyria, Wolfram syndrome, Friedreich's ataxia, myotonic dystrophy. Gestational diabetes, now this is type 4 diabetes. It had been classified under type 4 diabetes and is most frequent cause of diabetes in childbearing age in young females. So its frequency is increasing since last few years, so it has become has been classified separately. Gestational diabetes termed when diabetes mellitus is diagnosed in second and third trimester of gestation. When it is appearing in first trimester, then it will be labeled as pre-gestational diabetes mellitus, and it should not be labeled as gestational diabetes mellitus. 35 to 60% of ladies who are suffering from diabetes mellitus in pregnancy, they may develop diabetes mellitus, full-blown diabetes mellitus in later age. And also children born to gestational diabetes mothers, they also are likely to develop type 2 diabetes mellitus or other metabolic syndromes at later age. So which type of diabetes is most common? So around 90 to 95% of patients which we encounter now in clinical practice, they are usually type 2 diabetes mellitus. So type 2 diabetes mellitus, most common diabetes mellitus, rest is usually type 1 and other 3 and 4 type. They constitute only 5 to 10% of total cases of diabetes mellitus. So in type 1 diabetes mellitus, what are the empirical risk of development of type 1 diabetes mellitus up to 25 years of age? If both parents are diabetic type 1, chances are their offspring or their kids have 15 to 20% chances of developing diabetes mellitus type 1. If father and mother are separately diabetic, so if father is diabetic, there is 2.5% chance of developing diabetes in such kids born to the father, and 1.5% in case of mother affected by diabetes mellitus. If mother and sibling both are, one of the kid is suffering from diabetes, the chances increases to 13% in such other offsprings. So other siblings may develop diabetes mellitus in good number. 13% patients may develop diabetes mellitus. If there is monozygotic twin, one of twin is suffering from type 1 diabetes mellitus, chances are 40% that another kid will also develop diabetes type 1. So risk factor of type 1 diabetes, we already discussed. If one of the monozygotic twin is diabetes mellitus type 1, chances is 40% times that another kid will also develop, monozygotic twin will develop diabetes mellitus type 1. If both parents are diabetic, then chances are 15 to 20%. If mother and one sibling are diabetic, chances are that another sibling will develop diabetes is 13%. So risk factor of development of type 2 diabetes mellitus. So which kind of risk factor we will go through that? If family history of diabetes, parents or siblings are type 2 diabetic, then chances are very high that another kids or siblings will develop diabetes type 2 diabetes. If patient is overweight or obese and BMI is more than 25 kg per meter square, if there is physical inactivity due to their habits or profession, race and ethnicity plays a great role. So African American will have diabetes mellitus more times. Previously identified with intolerance of fasting glucose, impaired fasting glucose or impaired glucose tolerance, or if hemoglobin A1C is 5.7 to 6.4%, then chances of development diabetes in such patient is more. If there is history of gestational diabetes mellitus, chances to mother as well as to kids born to during this pregnancy may develop diabetes mellitus at later age. If patient is having hypertension or HDL cholesterol level is very low, less than 35, chances of development diabetes high in such patients. Also in PCOD patients and acanthosis nigricans, chances of development of diabetes are very high. So risk factor we already discussed. Here we see how we diagnose diabetes mellitus. In normal glucose tolerance, if patient's fasting plasma glucose is less than 100, patient is normal, he is not diabetic. If 2 hours postprandial glucose is less than 140, he is normal or normoglycemic patient. HbA1c is lower than 5.6%, then patient is normoglycemic. If in pre-diabetics, the blood sugar fasting will be between 100 to 125 milligram percent, 2 hours postprandial will be 140 to 199 milligram percent, and HbA1c if 5.7 to 6.4, they are labeled as pre-diabetic. In diabetic mellitus, so if fasting glucose is more than 126 or postprandial glucose more than 200 milligram percent or HbA1c is more than 6.5%, then they are termed as diabetes mellitus diagnosed, full blown. So this is same slide only, we have explained in a different way. And what are characteristic different type of diabetes mellitus? So type 1 patient usually have lost their 70 to 80% or more of the insulin production capacity, and they can be controlled only with the insulin. Insulin is needed for survival of such patients in type 1 diabetes mellitus. They readily develop ketoacidosis if they miss even their single dose of insulin. So this should be explained well to their such patients and their attendants. So utmost care should be taken for their management, and parents should be counseled accordingly. If a young person of 25 years is affected with diabetes mellitus and is controlled well with the oral medication initially, probably he is a case of MODY, that is maturity onset diabetes mellitus of young. Type 2 diabetes mellitus is usually termed as a lifestyle disease because this happens in obese and inactive persons with poor dietary habit and who have got high BMI. These patients should be prompted for lifestyle changes. They should be advised for high activity, reduce their weight, and their dietary habit should be checked and should be stopped. That is, they should not consume more fast food and sugary drinks. It may halt its propagation and may reverse the diabetes mellitus. They do well on OHAs. Such type 2 diabetes mellitus, they do well on the oral hypoglycemic agents, and they require insulin only when their insulin level falls below 90% of the baseline level. That is around 10 to 20 years of diagnosis of diabetes mellitus, they may require insulin for better control. They usually develop severe hyperglycemia, when they are under stress or if they are undergoing surgery. So any surgery or infection can lead to severe hyperglycemic coma in these patients, but usually ketosis or acidosis is very rare, and if developed, they will be readily reverted and they respond well to insulin therapy. Within 1 to 2 days, their ketosis will go away, and usually this hyperglycemia will revert well with treatment. So type 2 diabetes mellitus should be diagnosed by fasting glucose level more than 126 in venous blood samples, which is done in our laboratories. Another is self-monitoring blood glucose monitoring by fingerprint method. Nowadays these instruments are available very cheaper cost, and the strips are also affordable. They give usually higher glucose level as compared to venous blood because sugar level is high in capillary blood. This finger prick usually check capillary blood. So levels are little higher than as compared to venous blood. If fasting sugar level is between 100 to 125, it is termed as a pre-diabetes. By HbA1c, we already saw that these patients, if HbA1c is more than 6.5, then we should suspect for diabetes mellitus. If it is between 5.7 to 6.4, they are labeled as pre-diabetic. Venous plasma sugar is usually used in the laboratory. It is a standard method of measuring blood sugar. Capillary blood method used in finger prick method by glucometers, and it is mostly used in home care, that is self-monitoring blood glucose at home. So it usually gives slightly higher level of glucose as compared to venous plasma method. Arterial method by ABG machine, it is more accurate and gives higher level than glucometers, which usually is by capillary method, while by arterial method still higher blood sugar level will be seen. Thank you very much.